Good afternoon, everyone. Thank you so much for joining today's webinar. My name is Kate Morales, and I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep United. Welcome to today's webinar on hepatitis B in Sub-Saharan Africa. Before we get started, I'd like to review a few housekeeping items and let you know how you can participate in today's session. Please note that all attendees are in listen-only mode and you'll be muted during the presentations. In case you're having any audio issues, there is a phone-in option and the call-in numbers are shown here. Additionally, you may submit questions in writing during the presentation by typing them in the question box on your GoToWebinar control panel. We'll be reviewing them as they come in, and we will hold a Q&A period after both presentations. And finally, today's webinar is being recorded. You will receive an email with a link to view recording within a few days after the presentation. Before we get started, I just wanted to share that today's webinar is being presented by Hep United. Hep United was founded in 2012 by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. It is a national coalition of over 35 organizations across 18 states and the District of Columbia. Our mission is dedicated to reducing the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities. Members of our coalition are community-based hepatitis B coalitions themselves, comprised of stakeholders from a variety of sectors, including health clinics, local or state health departments, community-based social service organizations, as well as academic research institutes. We serve as a voice for hepatitis B advocacy locally and nationally, advocating for increased resources for hepatitis B prevention and treatment. Now I'll go ahead and introduce both of our panelists today. Our first speaker will be Dr. Yusuke Shimakawa. Dr. Shimakawa is a senior epidemiologist at the Institut Pasteur in Paris. He specializes in the viral hepatitis epidemiology in Africa. Dr. Shimakawa did from Japan, a diploma in tropical medicine from the Nagasaki University, and a master's and doctorate in epidemiology from the London School of Hygiene and Tropical Medicine. From 2012 to 2014, he spent 3 years at the Medical Research Council in the Gambia, West Africa, for the first treatment program of HBV mono-infected people in Sub-Saharan Africa called Prolifica. Currently, he is leading a community-based study to prevent mother-to-child transmission of HBV in Senegal, Burkina Faso, and Madagascar, and a study to develop and validate tools to diagnose HBV in Senegal. And then our second speaker is Dr. Tamara Gauss-Vernick. She's the Director of Research and a group leader of the Medical Anthropology and Environment in the Emerging Diseases Epidemiology Unit at the Institut Pasteur. She's a specialist in the medical anthropology and history of Central and West Africa. She has led research on Sub-Saharan African understanding of hepatitis B and vaccination, as well as diagnosis, itineraries, and access to treatment for those living with HBV. Over the course of this research, she has also worked closely with healthcare workers and patient associations mobilized for access to hepatitis B treatment. She has led research on a wide range of other global health problems in Africa, including zoonotic disease. So we're very excited and welcome our two panelists here, and we're excited to hear from them. So I will go ahead and turn it over to our first speaker, Dr. Shimakawa.
Thank you very much for Kate for introducing us, and thank you also organizer for giving us this great opportunity to present about problematic of hepatitis B in South Africa. So next slide, please. So first, I'd like to draw the attention that until recently, when we talked about global infectious disease, global health problem, it has been always HIV, TB, and malaria. But next slide, please. Thanks to the global burden of disease study, now we know that viral hepatitis, which includes hepatitis A, B, C, and E, kills much more than tuberculosis and malaria, and as many as HIV. So this is very clear that it's global public health problem. Next slide, please. And until recently, for example, in the Millennium Development Goals developed by the United Nations, it only targeted HIV/TB, malaria, and also Global Fund is on for this disease. However, in the next UN target for the development, viral hepatitis is included. So it's really great news. And next slide, please. And subsequently, WHO has also examined the possibility of elimination of hepatitis B and hepatitis C as a public health threat. And now we are aiming to reduce by the year 2030 the incidence of new chronic infection of hepatitis B and hepatitis C by 90% compared to 2015, and the mortality from chronic infection by 65%. And next slide. So in order to achieve these goals, there are a couple of interventions, and one of the quite important and challenging intervention is to increase the treatment coverage in chronic carriers eligible for antiviral therapy, which is estimated at 8% currently in 2015, but it should be 80%. But this is not the This is not the only target in those countries. It's for global target. And next slide, please. So when we look at this map, which shows the prevalence of HBs antigen, which is a marker of chronic hepatitis B infection, it is clear that the infection is concentrated, high prevalence in Sub-Saharan Africa, particularly in West and Central Africa. So in order to achieve objective of elimination, we have to really spend a lot of our energy focusing on these areas with high prevalence. And of course, in Southeast Asia and in East Asia, there are some countries with high prevalence. And next slide, please. And globally, about 50 to 60% of liver cancer, hepatocellular carcinoma, are attributable to hepatitis B virus infection. Area with high prevalence of hepatitis B overlaps with area with high incidence of liver cancer. So we can clearly see that West and Central Africa and the rest of Sub-Saharan Africa, they carry the high incidence of liver cancer. Next slide, please. So today, my first important message is that in Sub-Saharan Africa, most people have been exposed to HBV during childhood before the introduction of hepatitis B vaccination. Next slide, please. So, this pie chart represents a frequency of mode of transmission among those who became chronic carrier of hepatitis B. So both in East Asia and Sub-Saharan Africa, historically, most of people have been exposed to HBV by the age of 15 or 16 years old. But in East Asia, mother-to-child transmission plays quite important role. So about 40% of chronic carrier acquire the infection through mother-to-child transmission, and the rest of carrier through childhood transmission, horizontal transmission. Whereas in Sub-Saharan Africa, the proportion of mother-to-child is slightly lower than East Asia, and the horizontal child transmission is important. And next slide, please. So I'm going to present most of the data from the Gambia. So I would like to show where it is. So Gambia is the smallest country in the African continent, where there's about 1.5 million people living, and the prevalence of hepatitis B is between 8 to 10%. Next slide, please. So this is a study conducted in 1980s in the Gambia, which shows seroprevalence in children according to different age group, and x-axis shows age in years for children. So as you can see here, and also black bar and shaded bar show those who are positive for HBs antigen, so those who became chronic carrier, and white bar represent HBs antigen negative, but antibody against hepatitis B core positive, which means that people who have been exposed to HBV, but who are not actually chronic carrier, but who have been exposed, so past infection. So as you can see here, between 0 to 1, the proportion who has at least one of these markers is quite low. So it shows that mother-to-child transmission certainly exists, but it's not major mode. And next slide, please. But between 1 to 13 years old, each year the proportion who have at least one marker of HBV increases steadily. And next slide, please. And by the age of 13 to 14 years old, 90% of people have at least one marker of hepatitis B. So it means that most of people have been exposed to HBV, but out of those 90% of people who have been exposed to HBV, only 10 to 15% became chronic carrier. And horizontal transmission during childhood played a major role. Next slide, please. And this was not unique in the Gambia. In other countries, in other Sub-Saharan African countries have also demonstrated similar epidemiology. So this table presents this is the summary of the study conducted in 1980s and 1990s, early 90s, before the introduction of hepatitis vaccine in these countries. But all these studies show that almost more than three-quarters of general population, adult population carry at least one HBV marker, which shows that only less than 25% or 20% of people can be susceptible to infection during adulthood. Next slide, please. So next message is this is the same thing. Transmission during, so because there are so few adults who are susceptible during adulthood, transmission during adulthood is not very frequent, despite high prevalence of hepatitis B. So this can be suggested by a study case series of acute jaundice, acute hepatitis, which look at the proportion who have hepatitis A or hepatitis E or hepatitis B. So if you look at case series in Senegal, Chad, and Nigeria, all these countries have high prevalence of hepatitis B, more than 8 or 10%. But case series of acute hepatitis, those who had anti-HBC IgM, which is a marker of acute hepatitis B, the proportion was only between 0 to 22%, even though these three countries have high prevalence of hepatitis B. So this means that, and the rest of people who don't carry this antibody is either hepatitis C, and there is a tiny proportion of hepatitis A. But this represents that acute hepatitis B is not very much frequent despite high prevalence of hepatitis B, because there are so few susceptible adults in this region. Nevertheless, I have to also underline that conducting this kind of acute jaundice study in Sub-Saharan Africa is quite complicated, because in my experience in the Gambia, for example, people who develop acute jaundice, they do not seek Western medical attention. They do not go to a hospital clinic, because those problems, they call it yellow fever, and they think that this should be solved by the by herbal medicine or traditional healers. So this part can be much more discussed by Tamara in the next presentation. So next slide, please. And another interesting point in Sub-Saharan Africa is that, for example, in North countries like Europe or in North America, co-infection with hepatitis C or HIV is quite a big problem among those who are infected with hepatitis B, because HBV, HIV, hepatitis C, all these share the common root of mode of transmission. However, as I mentioned earlier, in Sub-Saharan Africa, historically, most of people have been exposed either mother to child or horizontal transmission by the age of 15 years old. Major mode of transmission is different from that of hepatitis C or HIV. Therefore, prevalence of co-infection with HCV or HIV is not particularly high in HBV-infected people compared to those without chronic HBV infection, like general population. And for example, in the Gambia, population in a population-based cohort of chronic HBV carrier, prevalence of co-infection with HCV was only 0.3%, and HIV was 1.0%, which was quite similar to general population. Next slide, please. But all these phenomena might be changed in the next 10 to 15 years. It's because now all these African countries have integrated hepatitis B vaccine within the EPI, Expanded Program on Immunization. So it's good news, it's great news. However, as you can see in this map, quite many of African countries have inadequate coverage of hepatitis B vaccine, 3 doses of hepatitis B vaccine. And this does not show burst dose vaccine to prevent mother to child. This is just for 3 doses of standard vaccine from 6 weeks up to 6, 10, and 14 weeks. And even some countries have coverage lower than 50%. Next slide, please. So this may change. We may have an epidemiological shift. So in the past, as I mentioned, more than 80% or 75% had naturally acquired, and therefore there are few susceptible adults, and acute hepatitis or co-infection with hepatitis C or HIV were not big problem. However, in future, if we could achieve high vaccine coverage, which is ideal situation, then of course we can eliminate hepatitis B. But if we continue to have inadequate coverage of hepatitis B as we see now, then it just increase age at HBV exposure, age at HBV infection, and acute hepatitis, and also probably more co-infection with hepatitis C or HIV. Next slide, please. So this is last one. So liver cancer is major public health problem in the region. Next slide, please. So this figure shows this ranked the number of cancer deaths by type of cancer in Africa. So in male, liver cancer is the most common cancer, and in female, it's the third most frequent cancer. Next slide, please. And in the Gambia, for example, hepatocellular carcinoma is the most frequent type of cancer, and 60% are due to hepatitis B infection. However, even though this is an important public health problem, only less than 1% had ever heard about HBV infection and had been tested for HBV in the past. And most people remain undiagnosed until later stage of disease when prognosis is poor and treatment options are limited. Next slide, please. And unfortunately, there is no curative treatment. Hepatic surgery is not possible. There is no ethanol injection. There is no radiofrequency, so there is no cure. And surprisingly, there is even no care. There is even no palliative care. As you can see in this picture, this is a 40-year-old man who developed liver cancer, and we can see that there's a protruded tumor from the abdominal wall. And we did liver cancer patients case control study, and our clinic was kind of referral center in the country for the liver cancer. So we asked patients who are referred from a general physician. We administered a standardized questionnaire for their pain and for their symptoms. And even though they have been already seen by their local physician, most of them suffered from quite severe pain. And surprisingly, more than half of these patients who have been referred from the physician have not received any analgesic, as this is shown in the pie chart. And most of those who are given analgesics were given just paracetamol, and only few are given like tramadol or codeine, and none received oral morphine. So this illustrates that curative treatment in resource-limited countries is complicated, but even palliative care, which should be affordable, cannot be provided in this context. So I think I'm running out of time. So can you please skip next 3-4 slide, and I think Tamara's presentation can be followed. Thank you very much. So please skip all these.
Great.
So you
Okay.
don't want to summarize? Oh, okay. Hello?
Well, we may have some time at the end to cover those slides, but thank you so much, Dr. Shimakawa, for that great overview about the prevalence of hepatitis B in Africa. So we'll now move on to Dr. Gauls-Vernix. I'll turn it over to you.
Okay. Thank you, Kate, for this marvelous opportunity, and thank you, Yusuke, for a very clear presentation. Now, as a medical anthropologist and historian, working primarily in Western and Central Africa, I've actually never worked with African migrants in the United States. So I don't know in any details the kinds of challenges that some of the participants today are confronted with. But I hope that what I'm about to say will help you with your work, and also hope that you feel free to ask any questions of me and of Yusuke that will help you do that work better. Next slide, please. So I just want to start with two preliminary points. What I'm about to discuss is highly selective. In fact, limited largely to 4 countries in which I and my team have worked. That is Senegal, Burkina Faso, Central African Republic, and Madagascar. And so we really can't generalize from these 4 sites to an entire continent. So for some of you listeners, there may be things that are missing. In fact, though, there are very, very few published anthropological studies available in these countries. There are a couple of anthropological studies that have been conducted in Côte d'Ivoire, in Ghana, a little bit of anthropological work that's been done on hepatitis C in Cameroon, but generally very, very little. Now, so for those of you who aren't familiar with medical anthropology, I'd like to just make a couple of points about how we work. We do a lot of on-the-ground work trying to understand the world's health and illness from the perspectives of people living in the locations where we're conducting research. And we use specific tools of anthropological inquiry, like open-ended interviews, participant observations, to get at how people, their families, and neighbors think about and experience the illnesses with which they're living, what they think the causes of those illnesses are, how they gain access to care, and what kinds of care they gain access to. We also spend a lot of time speaking with and observing healthcare workers, trying to understand what it is that they know, living and working conditions, the presence or absence of certain kinds of resources, how they cope with the challenges of a lack of resources, for instance, like painkillers that Yusuke was talking about. And we also observe diagnostic announcements and consultations, vaccination sessions with various healthcare settings, all the way from village clinics to urban hospitals. Next slide, please. So what is hepatitis B in Sub-Saharan Africa? Now I'm thinking about this anthropologically. How is it understood by people? What's of foremost importance is that it really doesn't exist as a category of disease for most people with whom we've worked. We have never been able to identify a local category of disease that corresponds with hepatitis B. Among well-educated, kind of urban people, there's very limited recognition and almost none in rural areas. Why? So partly I think it's because of what Yusuke explained of its natural history. HBV infection occurs pretty early in life and remains invisible to those with chronic carriage for decades. They only, if you, I'll talk about this later, but if you end up manifesting symptoms, these are usually symptoms of end-stage liver disease. So there's this kind of disconnect between the biomedical cause, which may occur early in life, and what people experience in their bodies. A second reason that hepatitis B doesn't really exist as a disease entity is because health worker knowledge is quite partial. And even when confronted with a symptomatic case, HBV may not be on their radars. For those workers who do know of it, they may lack the terms, in fact, to talk about it. The French term hépatite B isn't always meaningful to patients, and so they struggle to find another local language term for it, but this can end up causing even more confusion. In addition, in low-resource contexts, people suffer from a lot of other sicknesses, and symptoms can be vague and confused with other more easily recognized pathologies like malaria. And there's a lot of self-diagnosis and treatment going on at home for these illnesses. So those local diagnoses are often based more frequently on various symptoms. So, for instance, in Central African Republic, people do recognize clearly jaundice. They call it leti mafuta, which means palm oil eyes. Like, how the whites of someone with hepatitis, the whites or other kinds of jaundice might have yellow eyes, and le is eyes, and mafuta is palm oil, so it's evoking the color of palm oil. And finally, the disease category hepatitis B doesn't exist because lay people may offer alternative explanations for it, and particularly sorcery. Now, this is a challenging subject to explain. It's often exoticized and dismissed by outsiders and others as kind of old, outmoded ways of thinking about illness. But for those of you who are providing clinical care and confronting people who espouse this particular alternative explanation, I have some just preliminary thoughts. First, this is quite real for people. Weight loss, abdominal swelling can be read as signs that someone is being ensorcelled, has had some kind of misfortune visited on them through the manipulation of occult forces. Sorcery explanations are effectively a way of explaining misfortune, but one that can also at certain points be compatible with biomedical explanations. So someone can be suffering from end-stage liver disease as a consequence of hepatitis B, openly acknowledge that they have a hepatitis B infection, but still conclude that this illness was thrown or launched by a specific responsible person manipulating occult forces. So the point here is that sorcery explanations can be quite flexible to accommodate both, in effect, both kinds of explanations. Finally, it may be helpful to accept a kind of causal coexistence rather than arguing, in effect, about what has caused a patient's illness. It may simply be helpful to acknowledge, and some of you may have already discovered this, acknowledge that there's a kind of coexistence of multiple explanations, and to focus effectively on the need for monitoring and treatment. Next slide, please. So how are people diagnosed? Most of the time, asymptomatic people will discover through blood donations. In some of the locations that we've worked, there's a lot of mobilization blood drives in high schools and university settings, and so young people will go in simply because they want to donate blood and get tested and end up getting screened and discover that they are chronic carriers of hepatitis B. In cases where people are symptomatic, the process is much more circuitous and often quite lengthy, with people struggling to find what it is that's making them sick, and circulating to health clinics, diagnostic laboratories, hospitals, oftentimes traditional practitioners who are quite contemporary in their efforts. They will send people to diagnostic labs. Sometimes the blood bank is the last resort. We met somebody who said, well, if I've really got something wrong with me, they won't take my blood at the blood bank. And this kind of circuiting to all of these different locations can take a huge amount of time and can entail quite significant expenses. In some cases, these diagnoses are a direct result of someone with end-stage liver disease, and in some cases, the diagnosis is sort of ancillary to something else that's actually been afflicting the person. Next slide, please. One of the issues that we've been confronted with has been the massive influence of HIV on understandings and explanations for hepatitis B. Now, to be sure, the history of political mobilization around HIV offers, I think, a productive model for political mobilization around hepatitis B and activism for prevention, diagnosis, and treatment. But the fact at least that we've found in our sites of research, that both lay publics and health workers use HIV to explain what hepatitis B is also has some negative consequences. First of all, stigmatization. We know that the devastation that the stigma of HIV can cause, and there's still an enormous amount of work to do here. But making hepatitis B analogous to HIV effectively reproduces that stigma and in multiple domains. So, for instance, one woman in a rural village described to us that as she grew sicker with liver disease from hepatitis B, people in her village began to avoid her. She said, well, everyone said I was finished. People looked at me in a bizarre way. Rumors began to circulate that it was that sickness, AIDS. And in truth, I'm quoting here, in truth, I started to wish even for my own death. And I would suggest that it's not just from how terrible she was feeling physically, but the fact that this woman was experiencing a kind of social death vis-a-vis her family and neighbors. But this stigma is also being perpetuated by well-meaning health workers themselves. I've heard health workers in the course of diagnostic announcements talk about hepatitis B, explain that hepatitis B was transmitted sexually, quote, just like HIV. And we know that that's largely not the case. And then they use terms like clean blood and clean living to patients. Now, this kind of language is devastating for those living with hepatitis B, or for that matter, any other illness screened. Relatedly, health workers responsible for diagnosis and relying on HIV to explain hepatitis B sometimes tell patients that there's no treatment available, when in fact there is a treatment to prevent liver damage. The response is that patients are terrified. One young man told us when he heard the diagnostic announcement, he said, the announcement of my diagnosis was so brutal that I was already digging my own grave. Many people have told us for over the years that hepatitis B is the little brother of HIV, the illness that cannot be treated. So bereft of any help, they don't get the help that bereft of any hope, they don't get the help that they really need. Some tend to consult online resources which are not written to address the specificities of HBV in Sub-Saharan Africa, about which Yusuke just spoke, and others consult traditional practitioners, which I'll talk about in just a minute. Next slide, please. Now, once diagnosed, patients' linkage to care, their ability to get access to monitoring, care, and treatment if they need it, is a significant problem in the places where we work. In one anthropological study that we conducted, 3/4 of the people that we spoke to achieved no linkage to care. Why? Well, again, the lack of training among health workers is a problem. Note, I want to say that this is not to castigate the health workers. The two health workers, the woman on the right and the woman at the top, I mean, these people, one is a nurse, one is a physician. These people are heroes. They are incredibly dedicated professionals, but massively overworked and underpaid. And I've had the physicians, nurses, and nurses' aides all tell me, I know next to nothing about hepatitis B, and I wish I knew more. So it's little wonder that we witness in diagnostic announcements or hear from patients that some health workers tell them, you have hepatitis B, there's nothing we can do, there is no treatment, go see a traditional healer. Another problem inhibiting patients' linkage to care is that long-term monitoring is really expensive, especially in these which are these are resource-poor countries and some of the poorest countries in the world. The tests, the monitoring that they have to follow is beyond the means of these people, and there are very few laboratories in which to conduct these tests, often just in the capital city. Patients' understandings of their illness can also be a barrier to linkage to care. Those told there's no cure and no treatment feel as if they've just been handed a death sentence. They're discouraged, in despair. They sense that nothing can be done. Some have troubles accepting that if you're a chronic carrier of hepatitis B, you need monitoring, but not necessarily treatment. The idea that if you're sick, you need a pill or an injection is widespread in our research sites, and I would imagine that's something that listeners have also encountered. The absence of any noticeable symptoms often leads people with chronic carriage to think, well, I don't feel sick, so I'm just going to wait until I feel bad and then I'll pay for monitoring. And this is especially a problem in low resource countries, but I would guess this is something that some of you also have to address. And finally, there are more visible offers of treatment. Self-treatment is huge in the places where we work, even in the poorest ones. And you can get antibiotics on the street in Bangui in 30 seconds. A couple of years ago, I spoke to a young man whom I was interviewing in Bangui, who'd been diagnosed as an asymptomatic chronic carrier of hepatitis B, and who was taking tetracycline every day, thinking that it would help him with his viral hepatitis. And I begged him to stop, saying that it was great that he wanted to keep himself healthy, but taking antibiotics every day was going to do more harm than good. Next slide, please. So what we do find is a really extensive use of, I've got traditional practitioners in scare quotes because these people are not so traditional. In some cases, we found, actually in many cases, we found formal health workers referring, that is in blood donation centers and the like, referring patients to these traditional practitioners. And there is a huge offer of services and remedies in West Africa. These are pretty sophisticated people. They're sending, I've gone through the notebooks of some of these people. They have notebooks of all of their patients who they've sent to go get HBs antigen testing. As you can see from some of these pictures here, the presentation is pretty sophisticated. They formulate capsules, teas. You can see the packaging is quite nice, and there's widespread marketing at national and regional fairs with distribution around the world. Often through kinship networks, people will have someone, for instance, in Ouagadougou or in Dakar, and will send them these remedies. The consequences, though, are problematic: medical, ethical, and financial. As everyone well knows, these remedies have not gone through rigorous testing and may potentially harm patients. There are no clinical trials to test the efficacy of them. And because these products are mostly unregulated, the effects, as I think everyone knows, can be deleterious for patients' health. Patients also don't really know what they're taking, and they are not aware that traditional healers may in fact be experimenting on them. This is an ethical problem as well. And the other thing is that they're very expensive. People with whom we've conducted interviews seem to have this great confidence in these healers, but also think that consulting and getting treated by them is going to be a lot less expensive than going to a regional or capital health care center and getting monitored. This isn't necessarily the case. I interviewed one man, a school director, who gave me all of the receipts that of money that he had spent on consulting a traditional healer after being diagnosed as a chronic carrier with hepatitis B. And we sat on the floor of his house and calculated the total of these receipts and concluded that he had spent over $1,600 US dollars on these medications, which included extremely expensive vitamins that did absolutely nothing for him. And I would remind listeners that this was in Burkina Faso, one of the poorest countries on the planet, $1,600. So finally, I think it would be a mistake, though, to conclude that traditional healers are somehow the option for people who aren't educated. People at all socioeconomic and educational levels in the countries that I've worked consult traditional practitioners. It seems that it's a kind of way of hedging bets. And this can be a problem if these are the same people who are taking antivirals and healers' remedies at the same time. Now, I do think that healers' work can be fascinating from an anthropological perspective, but in the case of hepatitis B and other forms of viral hepatitis, there are really significant medical, ethical, and financial problems introduced by their interventions. So next slide, please. My take-home messages. Hepatitis B is not widely known in our Sub-Saharan African sites, including among health workers, but alternative explanations, including those invoking sorcery, are quite widespread. Diagnosis can be accidental, that is through blood donations, or very lengthy and circuitous for people who are experiencing some kind of symptoms, and can be very difficult and can take years. Understandings of hepatitis B are strongly influenced by HIV, and that can be a problem. Linkage to care is a great problem in Sub-Saharan Africa, and traditional treatments for hepatitis B are quite easily available, but also, I think, pose some problems. Next slide, please. So we have many colleagues, collaborating institutions, funders, and most of all, I would say, informants to thank for their support. And final slide, please. And I'd like to thank all of you for your attention. We hope that this has been useful to you. Please don't hesitate to ask any questions you have. Now, I would say that this is, as Yusuke said, this is a global struggle. And despite the different challenges that we all face, I think it's important to remember that this is about our global future. So I want to conclude with a wise and wonderfully earthy Central African proverb that insists that one finger alone cannot extract a head louse. Yes, you heard that right. It always makes me laugh, but it also reminds me that we cannot and should not struggle alone. Thank you.
Great. Thank you so much, Dr. Giles-Vernick. That was really fascinating, and I'm sure we've learned a lot from both of you. So I'd like now to begin the question and answer portion of our webinar. And as mentioned in the beginning, we'll start by answering questions submitted to us via the chat box. So if you'd like to submit a question now, please do so using the questions field on your screen. And we do have a few questions that have come through the chat box. The first question is for Dr. Shimakawa. The question is, lately documents are focused more on the sexual transmission of hepatitis B, but it is known that mother-to-child transmission is the most frequent mean of transmission, especially in Africa. How do you organize screening of pregnant mothers, and how do you take care of pregnant women with high viral loads? A follow-up question is, what tests do you use in France for rapid screening, and what advice can you provide for the implementation of mother-to-child transmission in Africa?
Thank you very much for important question, but I think there are quite many important components within it. So I'm not sure if I can answer everything within short amount of time. But first, as I mentioned during my presentation, historically, before the implementation of the vaccination program in Africa, sexual transmission was a rather minor mode of transmission. And mother to child also is important, but it's not the major mode in comparison with horizontal transmission during childhood. However, now there is a hepatitis B vaccine, and most of the countries are giving with a schedule starting from 6 weeks or 8 weeks of life using pentavalent or hexavalent vaccine. Therefore, this schedule does not sufficiently prevent mother-to-child transmission. Therefore, after the implementation of vaccination program, mother-to-child transmission becomes more important. And also, certainly there will be infants who will not be vaccinated. We saw that vaccine coverage is inadequate. And for these children, there will be also less opportunity to be transmitted in the community because large pool of infected infants will be reduced. Therefore, they can continue to be susceptible and they can have more chance to get hepatitis B through sexual transmission. Therefore, both sexual transmission and mother to child used to be a relatively minor mode of transmission in the past, but it is going to be a big problem, I think. And screening of women for hepatitis B. So this is a quite very important topic. And now, thanks to many of, I think, Asian studies and Western countries studies, which have shown the efficacy of doing screening for mother and giving antiviral therapy during third trimester up to 4 weeks or 8 weeks after the child delivery, which showed the prevention in terms of mother-to-child transmission. So subsequent to these studies, now American guidelines and also European international guidelines, they recommend to screen for HPV DNA for those who tested positive for surface antigen, subsequent screening for HPV DNA, and those who have high viral replication, like 200,000 international units per milliliter. Those women are recommended to take antiviral therapy to prevent mother-to-child transmission. But up to now, WHO has not yet made a clear recommendation for this because there is still not enough evidence, particularly from other parts of the world, including in Sub-Saharan Africa. And Asian evidence from Asian studies cannot be really directly applicable to African context because current standard of care in Africa in terms of prevention of hepatitis B is only hepatitis B vaccine, and most countries provide from 6 weeks of life. So even birth of the vaccine is missing in many vaccination programs. And in addition, all the Asian studies, they gave not only birth of the vaccine, but they also gave immunoglobulin at birth. And access to immunoglobulin is really complicated in Sub-Saharan Africa because of limited supply and also a need for cold chain, and it's expensive. So Asian evidence which shows that in addition to birth dose vaccine, in addition to immunoglobulin and maternal treatment cannot be directly applicable to Sub-Saharan Africa, where first dose of vaccine is given at 6 weeks without immunoglobulin. Nevertheless, I think in some countries now there's a good access to tenofovir or some antiviral therapy. So if they have afford to do this, I think it may be good to screen for mother for surface antigen, and for those who have surface antigen might be screened for HPV DNA. But again, access to HPV DNA using PCR test is also severely limited in Sub-Saharan Africa. So this is another challenge. And I think now there are a couple of studies which are trying to develop and evaluate some markers which can replace HPV DNA PCR. So this is another important area. So I'm sorry, I cannot answer very well to all these questions, but the current situation in Africa is very complicated, but I think we should continue to answer all these important questions through conducting research and also implementing public health strategies.
Great. Thank you. Our next question is, what is your suggestion for a strategy to involve African organizations in solving the high burden of hepatitis B in Africa? Tamara, do you want to take that one?
Sure. I think that's actually absolutely a crucial question, and I think I'm trying to figure out where to start with it. I mean, I think, where I've seen the most active work among associations has been in Burkina Faso, mobilizing on the part of people who have been diagnosed with hepatitis B. I don't know that I have actually a specific strategy in mind, but I think that they need to be incorporated into, and for instance, were in In fact, when the government of Burkina Faso was putting together basically a national strategy, a national plan, these organizations were at the table, basically talking about the kinds of needs that patients have, the challenges that they face, what needs to be provided, and the like. So I think that those associations need to, they've been a really important part of the work on the research on the ground that I and we have done. But I also think that they need to be incorporated into national strategies and global strategies, because they are the associations that are really most in touch with the patients themselves, and I think have a really good sense of the challenges that they're facing.
Thank you. And this question, I think, relates to your point on HIV. How can we in Nigeria catch up to the level of awareness that HIV has here? This is a silent killer in Nigeria.
Can you repeat that question?
The question is, how can we in Nigeria catch up to the level of awareness that HIV has here?
Oh, yeah. Okay. It's a difficult, I'm hesitating because it's a difficult question to answer. I think it needs to be talked about. I think it needs to be talked about through various kinds of media outlets and publicized, but publicized in a way that makes a linkage between the symptoms of liver disease that people recognize and what's happening probably earlier in life with the modes of transmission and infection. So it needs to be done in such a way that takes into account how people understand what happens when you're 40 or 50 years old and begin to show signs of liver disease and the beginnings of transmission. But I think that it's something that needs to be discussed at all levels. It needs to be discussed in village clinics, but also I think that healthcare workers need the training. They need to understand this better. This is something that we've actually tried to work with people in Burkina Faso, was developing, in fact, a kind of diagnostic announcement that gives health workers on the ground some kind of information and ways of discussing what hepatitis B is. I also think that, as an anthropologist, finding the right language to do it is really important as well. We've seen that the French term doesn't work in Francophone countries, and there's not any real consistency in the local terms. For instance, in Jula, in the terms that people use to refer to something that might be analogous to hepatitis B. So probably work with linguists to come up with a common term in some of these places might be really helpful too.
Great. The next question is related to traditional medicine. What is being done to integrate traditional medicine into healthcare delivery? Is there anything being done to ensure patient safety when going to traditional healers?
The state, and I really only know about in Central African Republic, there was an organization that was associated with the Ministry of Health and no longer exists. And it's difficult to talk about what's going on there, particularly because this is a country that's been experiencing huge amounts of instability and civil war for the last several decades. In Burkina Faso, what's really interesting is that if you go to certain sort of town, that's a small city health centers, in some places you will actually see a section of that health center devoted to traditional medicine. So there is an effort to integrate it into a kind of biomedical setting, but there's no real oversight there. The other thing that the Burkina government has done is that they've offered to traditional practitioners who come up with some kind of a remedy that they will conduct testing on to see whether there are toxins in the remedy. So they don't do any kind of clinical study on whether it's efficacious, but rather do a test to see whether there are toxins. And in that case, these remedies may be officially listed with the Burkina Faso government. Now that was a few years ago. I don't know whether that's still continued, but that was something that I was aware was being done a few years ago. But to be honest, to my knowledge, there isn't a whole lot, and it's pretty unregulated. And yet, you can go to these. I went to the Sirena fair in Ouagadougou a few years ago, and it was massive, and I was stunned at how many people were offering remedies from all over West Africa for hepatitis B.
I would like to share, if the time still remains, I would like to share my experience in the Gambia. So we run a clinic for hepatocellular carcinoma patients, liver cancer patients, as well as all the end-stage liver disease patients. But some patients, they left from our palliative care program and they went back to the traditional healers. But for these patients who have ascites with swollen abdomen or protruded tumor from abdominal wall, traditional healer explains them that there is some obstruction within intestine. Therefore, you have to expel out this obstruction. Therefore, traditional healer often give herbal medicine which have emetic effect or laxative. So therefore, those patients who have already end-stage liver disease, they have deteriorated liver function, and finally they come back with liver failure. And we lost 2-3 patients with this kind of itinerary. So therefore, I personally do not have a good experience with traditional healers.
Mm-hmm. Thank you for that. Our next question is for Dr. Shimakawa. What are the ways in which horizontal transmission is occurring among children? And why is it higher in African countries than in Asian countries?
Great question.
Yeah, so the frequency of, as I said, frequency of mother-to-child transmission is much higher in Asia than in Africa. So first reason is because both areas have even though both areas have similar prevalence of HBs antigen in mothers, so about 8 to 10% of mothers carry HBs antigen. However, among those who carry HBs antigen, those who also carry hepatitis B E antigen, which is a mark of high viral replication, can really transmit the infection. And the proportion of chronic carrier mothers who have E antigen is quite different between Asia and Africa. In Asia, about 40% of HBs antigen positive mothers also carry E antigen, which is a mark of viral replication, whereas in Africa, only 10% of 10 to 20% of the surface antigen positive mother also carry E antigen. Therefore, the proportion of highly viremic mother is different between these two areas.
Thank you. And then we have a lot of great questions, and I think we have time for just maybe one more because I've seen a pattern in questions around rapid testing, and I was wondering if either of you have thoughts on this. One of the questions we received was, is the rapid testing for hepatitis B screening widely approved in affected countries?
Yes. So first screening test which should be done is hepatitis B surface antigen test. So for HBs antigen, there have been quite many validation studies, and we also validated in real life field context in the Gambia. And all these tests, which cost around $1 or $2, and which has quite high specificity, about 95 or 98% of specificity, and sensitivity is above, I think, 88 or 90%. And so it means that there is a 10 to 12% of HBs antigen positive who can be missed using rapid diagnostic test. But those patients tend to have low HBV DNA levels without a significant liver fibrosis, without ALT elevation. Therefore, they are not really eligible for the treatment. Therefore, I think we can safely use HBs antigen point of care test, rapid diagnostic test. However, after the HBs antigen test, we have to confirm the degree of viral replication using HBV DNA PCR, and that's where currently there is no point of care test, there is no rapid diagnostic test. So, and hepatitis B E antigen can be a good, maybe good marker for viral replication. But we recently did a study in Senegal looking at their sensitivity and specificity, hepatitis B antigen rapid diagnostic test compared to the conventional laboratory-based immunoassay. And we found that we tested 3 different commercially available hepatitis B antigen rapid diagnostic tests, and all of these had sensitivity of less than 50 or 40%, which means that over half of patients who carry hepatitis B antigen can be missed using these rapid diagnostic tests. Therefore, I think there should be out of effort to develop a good point of care test or rapid diagnostic test to evaluate viral replication in those who identify to carry hepatitis B surface antigen.
Right. We're all hoping for that too. Well, we're a little bit over time, and wanted to thank everyone for sticking around. We do have a number of questions that came in, and I know we weren't able to get to all of them at this time, but we will reach out to you. If you would have any other additional questions for our speakers or for us, please do send us an email at connect@hepaunited.org. I want to thank both of our speakers today for sharing their expertise and their insights. It was very fascinating. And perhaps we can do a follow-up webinar to address some of the many other issues we could go on and talk about forever. So thank you both so much for your time today.
And thank you.
We wanted to let everyone know that we will be having another webinar that is international focused with the World Hepatitis Alliance within the next month or so. So if you have any questions related to the World Health Organization goals or connecting to international organizations, please join us, and we'll be sending out a notice with that, the registration within the next month. So thank you all so much for participating today. As you leave the webinar, please do look out for a survey. We would appreciate your feedback as you exit the session. And we will be sending around to all of our registrants and participants a copy of links to the webinar presentations, as well as a recording of the webinar. So feel free to share them, share the presentations with your colleagues. Thank you all again, and have a great rest of the day.
Okay, thank you.